Hi everyone, my name is Elisa. I am a second year Peds resident and I will be talking to you guys about the PICU and Gen Peds floor information. So we'll start on slide 14 with PICU. So basically it's on 8 Kellogg and there's 20 beds in total, but divided into two teams. So team one is the official PICU team, and these are gonna be the highest acuity patients. It's gonna be one PICU attending, a third year Peds resident who oversees the team, two second year Peds resident, and one second year ER resident. They have a total of 12 beds available to them. The other half is going to be team two, which is called the PICU step down or red team. It has three names. It's a little bit confusing. um, this is actually going to be a hybrid team that's combined with the Gen Peds floor, green and blue teams, but is housed in the PICU and has a PICU attending. It is PICU patients, trach, vent dependent, G-tube fed types of patients. However, they're going to be not actively dying. So this is going to be that PICU attending that we talked about, as well as a third year Peds resident and a Peds intern. This team has 8 beds available to them. In terms of location in the PICU, team one and team two beds are kind of intermingled. There's not like a set divider, like this half of the unit is team one and this half is team two. All of the beds are just intermingled. In terms of your schedule, you will arrive to the PICU. If you are team one, I'm only going to be talking about PICU team one right now. Red team will come later. PICU team one is going to go straight up to 8 Kellogg at 7 a.m. You're going to arrive and get sign up from an overnight on-call resident, and then pre-round, always make sure that you physically see your patients and do as thorough of an exam as possible. If it's going to be a more in-depth neuro exam, feel free to ask the resident to go with them, and that way the patient only has to be woken up once for a more in-depth exam. At 8 a.m., team one is going to start rounding. At 8:30, team two starts rounding. Once you're done, kind of pending census can be anywhere from 9 to 10:30. First things first, you're going to call your consults, follow up on labs, do any procedures that need to be done if somebody needs a central line, anything like that. Once you finish all the big tasks, you can start working on your notes. 11:45 to 1, we have noon conference and lunch. And then once we come back up at 1, it's really nice. I always like to go check in and just see my patients when we get back from lunch, just so I can say I touched base in the afternoon, see how they're doing since rounds. Following up with consult recommendations. So if you consulted POEM, what does POEM have to say? And then making sure you finish your notes before 4 o'clock. At 4 o'clock every day, you're going to sign out to whichever resident is on a 28 that night. As we said, the PICU team one is comprised of 4 residents. They each do call once every 4 days. So one person will be watching over your patients for the night. On Thursdays from 2 to 3 p.m., the PICU attending will do a resident lecture. And that is it. So big thing about PICU that's different from any other unit is going to be presenting on rounds. So rounds is going to follow this SOAP format. So subjective, objective, assessment, and plan. But what is unique to the PICU is the systems-based plan. So we'll get to what that means in a second. So you'll start with subjective. So you don't always need to give a super thorough one-liner on your patient. After your third time presenting this patient, everybody knows them. So at this point, you can just say, overnight, Max had these events happen. Big things to mention, did they have fevers? If they did have a fever, you always want to know what the Tmax was and what time. If we were weaning or increasing oxygen support, did they need more? Could they be weaned off? Same with feeds. Were they tolerating advancement of feeds, or were they puking all night? And basically any of the major changes in your plan from yesterday, how did those changes go? Also in subjective, if the patient is verbal, how are they feeling? And if they're nonverbal, but there's a parent, how did the parent think the child is doing compared to the day before? Next, you'll get to objective. So this is really nice to kind of keep your same order of things. We always like to start with vital signs. You can auto-populate those by just the dot phrase .vitals24. The biggest thing here to know is that vital signs are not the same as adults. Every age range is different. So in a newborn, a heart rate of 150 is actually fabulously normal. In an 18-year-old, a heart rate of 150 could mean a lot of scary things. Best thing to do here is always, when you take your vitals, is putting them into context. So you can just Google PALS guidelines, vital signs, pediatric, or some combo of those words, and you'll get the most recent kind of tables of what's normal. I always like to have those printed out and with me. Vent settings is another thing to have if the child is vent dependent, always making sure you include those after the vital signs. Then we do I's and O's. For O's, for outs, we always do in pediatrics, this is not PICU specific, urine output in cc's per kilo per hour. So if they had, for example, 1,000 cc's of urine and the kid is 10 kilos, you will do 1,000 cc's divided by 10 kilos divided by the 24 hours equals 4, whatever. Normal is generally 1 to 2, but always, again, put everything into context of the patient. So if the patient is on 2 times maintenance fluids, they'll probably, hopefully, have a little bit more than 1 cc per kilo per hour of urine. Next, you do your physical exam. Again, I think it's nice maybe on the first day to go through everything, but definitely if you're presenting a really stable patient on the 4th day, you don't need to go through every single system, but maybe just discussing the pertinent positives or negatives. For labs, next, it's always nice to know, again, what's normal. I think a big thing I always see with students is the kind of leaning towards what EPIC considers quote unquote normal. So sometimes, you'll have a glucose come back as 115, which EPIC will read as elevated and flag. However, if you think about it in a non-fasting patient who's receiving constant nutrition and has been eating, drinking an apple juice 10 minutes before labs, 115 is a totally normal non-fasting glucose. And then once you have those values, know which way they're trending. So if you have a kid with an AKI, every day you're getting CMPs or something, the creatinine that day is nice to have, but also is that coming down from the day before or going back up? And finally, imaging. The attendings will ask you to pull up many of the images, specifically like chest x-rays. So make sure that you don't just know the read from the radiologist. Dr. Cameron is wonderful, but also be able to pull up the image before rounds and take a peek and just make sure you kind of know what you're looking at and could walk the team through what you're seeing. Here's just a note on vital signs, which we already kind of talked about. PALS, which is kind of confusing, is basically our ACLS, but for kids, pediatric advanced life support. Next is going to be the assessment and plan. So assessment, always have your one-liner. And this is a really nice place to put kind of how are they today in the grand scheme of things? Why are they admitted? Why are they still in the PICU? What are going to be their discharge to leaving? And when they leave, where are they going to go? So kind of give us a big picture of what this kid is doing today and what's keeping them here and preventing them from whatever their next step is. And then you're going to go into plan. So there's systems-based. There's no technically correct order on which systems you do. Generally, I like to start, it's just nice to keep them stable across all your patients. So if you have 2 patients, make sure you're going through the same systems in the same order, even if one is a neuro patient and one is a respiratory patient. I generally like to start with cardiovascular or pulmonary, and then do the other one and then neuro. So I'll show you my order, but feel free to make your own order and just stay consistent. So when going through the plan, you can say cardiovascular and then go through things. Are they hemodynamically stable? Are they on pressors or other cardiac meds? Do they need daily EKGs, echoes, anything in that realm? So this is a great place to say, CV, this patient is in septic shock and their blood pressures have been X, Y, and Z. I would like to add this pressor agent or something like that. Then you have respiratory, so things like, are they on continuous pulse ox, or could you do, Q4 pulse ox checks? Do they need supplemental oxygen, or are they on room air? And then, of course, getting into any ventilator setting changes that you want to make. FENGI is both, this is a little confusing, on the floor and in the PICU, it is both a problem and a system. So fluids, electrolyte, nutrition, and gastrointestinal. Here is a system. So what kind of diet are they on? Do they need to be NPO for any procedures? What kinds of fluid and what rate are those fluids going at? And then any labs you want related to that. So any electrolytes, repletions, things like that. Renal, this is a nice place to put your I's and O's plan. So does this patient need strict I's and O's? Are they at risk for an AKI based on their medications? And then their overall fluid status is nice to go here as well. For neuro, this Complicated neuro checks are an obvious one, but one you wouldn't think to put here is going to be analgesia. So if the patient is on a PCA or a morphine, Tylenol, whatever the pain is, and then also therapies, physical, occupational, speech, all go under neuro. ID, you could talk about antibiotics, prophylaxis, things like that. Those are kind of the big ones to always have. Pending the patient, you could have like a derm, a musculoskeletal, endo, hemonc, social. These things you don't necessarily need to have for every single patient, but choose wisely. I just wanted to touch on a few of the hardware. The PICU attendings do wonderful lectures on all these things, but just wanted to go over briefly. In terms of ways to get oxygen, these go from least invasive to most. So you can start at a nasal cannula. This you can just have on the peds floor. Nothing crazy, they can get a liter or two of oxygen, no big deal. It's not humidified, it's not warmed, just some basic oxygen. More invasive, you can get high flow. These have longer prongs and the tubing is kind of taped to the kid's face. Oxygen can go up to like 60 liters a minute, which is not possible with the normal nasal cannula, which can get to some more of that dead space. It does, because of the higher rates, give you a little bit of PEEP to keep your airways open. And of course, your air can be warm and humidified. Next, you can get to BiPAP, which kind of blows bursts of air, as opposed to CPAP, which is continuous positive airway pressure. However, these all require spontaneous breathing. So your next step is, if these aren't working, do you need to intubate the patient and mechanically ventilate them? Or is this more of a chronic PICU kid? Are they already trached and hooked up to a ventilator at baseline? Once you have mechanical ventilation, so they're on a ventilator, the big ways we talk about how we give oxygen is either by pressure or by volume, which you guys will learn more about when you're up there. Next is going to be GI hardware. So there's a bunch of different ways to get food and nutrition into kids. Up at the top here is the nasogastric tube. Nasogastric provides things into the stomach. If you want to also decompress the stomach and take things out, you can have a special NG called a sump that takes things out as well. If you want to be what's called post-pyloric, you can throw an NJ or nasojejunal tube through the pylorus. This is kind of nice if you have a kid with chronic vomiting, reflux, so a lot of our pukey babies. This is nice. You don't have to worry as much about aspiration because you're post-pyloric, so you have something there to stop the reflux. So these are kind of short-term things. If you're talking about a longer-term solution, you can talk about a G-tube or a GJ tube. G-tubes are placed by surgery. You might hear PEG, Mickey, button. All of these are different types of hardware here. And then GJ is going to be so that you can give things more distally as well. J tubes are usually second line after G tubes are provided, and IR can exchange the G to a GJ. Finally, the neuro hardware, biggest one you're going to see is called a VP shunt, ventriculoperitoneal shunt, for kids with macrocephaly or obstructive hydrocephalus. You're going to drain CSF from the ventricles down through this little tube into the stomach, and essentially they are going to be able to pee and poop out their extra CSF. If you have a kid with a VP shunt, a lot of our chronic kids have things like these. Big things that you might want to mention on exam or kind of keep an eye out for. You're going to see this big squishy mass on their right kind of posterior parietal region. That's going to be the part that's in the ventricles. You're not going to see anything else except a small abdominal scar for where they had the end of the tube in the stomach. So things you might just want to look out for if you have a kid come up with one of these. Those are all the big things to know about PICU. They love to teach up there, so you guys will learn lots more details while you're there. Next is going to be the general pediatrics floor and this kind of red team, PICU team 2 step down hybrid team. So the Gen Peds floor essentially is a blue team and a green team. Both of these are housed in 6 Kellogg in the resident workroom. Blue team is going to be Gen Peds with some sprinkled hemonc. It's going to be a second year resident as your senior, an intern as your intern, and then you kind of have 2 attendings that you're going to run with, one a Gen Peds attending, and one is going to be a hemonc attending. On green, you have Gen Peds patients as well, usually a little bit more Gen Peds heavy, as well as your EMU patients, which is epilepsy monitoring unit, so kind of some Peds neuro. You're going to have a third-year resident here be your senior with an intern, a Gen Peds attending, and then also a Peds neuro attending. Sometimes neurology residents and students will also round with you. So generally here at 7, you're going to arrive. You're going to, same as PICU, kind of get your sign out from night float, go look at your patients. Around 8 a.m., you're going to round. At some point, kind of pending the week, generally around 9 or 10, somewhere in there, you're going to break off on your respective ones and do hemonc rounds if you're blue and epilepsy rounds if you're green. And then same as PICU, work on your patient care tasks, consults, labs, etc. 11:45 to 1 is noon conference and lunch. Coming back up, you can work on admissions, consults, notes, all of those things. And at 4, you go home as well. On the weekends, good thing to know here is that the green team, blue team, and red team up in the PICU all combine. So you're going to arrive at 7, same and pre-round normally, but on the weekends, feel free to wear scrubs and do table rounds. So we meet in the 6 Kellogg workroom with the attending at 8. They often bring breakfast, which is wonderful, and we just hang out in the room and call nursing in to round at the table. All these teams are combined. So if you need an OASIS diagnosis, let's say you're slotted to green team for your Peds Clerkship, but you need a hemonc diagnosis in OASIS, the weekends are a great time to ask to pick up a blue team hemonc patient. And, all the teams are combined, so the residents will know them all equally. That's that. So presentations on the floor are also SOAP, but these are going to be problem-based. So your subjective, objective, and assessment, all the same things we talked about, but instead for your plan, you're going to do problems. So let's say you have John Doe. He's a 9-year-old male with a past medical history of asthma, eczema, admitted for an asthma exacerbation in the setting of an RSV infection, requiring oxygen supplementation, now weaned to 1 liter of nasal cannula. He is tolerating his wean well, and we hope to discharge him tomorrow. That's a nice summary statement. And then you'll go into your problems. 1, biggest problem starts first, his asthma exacerbation, which is obviously why he's here, and X, Y, and Z, that's what I want to do about it. 2, you mentioned he also has eczema, so, are we giving him any emollients, anything like that? 3, like I said before, FENGI is both a system and a problem, so always make sure to throw in a diet order, I's and O's, things like that. Now, red team is a little confusing. So they are physically housed in the PICU, and you have a PICU attending, but the residents work more of the floor service. So like we said, on the weekend, you're cross-covering all the other floor patients. So here you have 1 senior Peds resident, so a 3rd year, a Peds intern, and a PICU attending. You're going to go to 6 Kellogg workroom, to the Gen Peds workroom at 7 a.m. to get sign out from Night Float, who's been watching your patients. And then once you get your sign out, you will go up to the PICU to pre-round. Finally, Night Float is going to be comprised of a 3rd year resident, 1 intern. They are going to cover the green and blue floor teams as well as the PICU red team. The 3rd year resident is also going to solo cover the nursery or the GCN or the MBU. We have a lot of names on Peds, I'm sorry. So for Night Float, arrive at 6:30 p.m. for sign out. You're going to meet in the 6 Kellogg workroom again for green team, blue team, and red team will all be down there. You're going to hear about all 3 teams of patients. What you do overnight is kind of dependent on the night. Some nights you're going to have admissions back to back the entire night. Other nights might be slower and you'll only have 1 or 2. You're more than welcome to sleep if you can. There's a student workroom on 12 Kellogg, or you can get one of the phones, one of the hospital phones, or exchange your personal phone with the residents, and they will text or call as admissions come in. So you can either try and sleep, or many people just prefer to flip their schedules. There's a wellness room on 6 Kellogg where you guys can play video games, watch movies in between things. In the morning, you'll sign out between 7 and 8 a.m. to the floor teams who are coming in. You are going to be paired with the 3rd year senior resident on Night Float, and that resident alternates with the intern on who stays to present a patient on rounds. So pretty much every other day you will present an admission on rounds and stay. That patient always goes first. So generally you'll stay until about 8:30. Other days you just go home after you sign out. So sometimes, you'll sign out your patients at 7 to 7:30 and then you're set to go. In terms of rounding overnight, very loose times, no set times for any of the rounds. Also no presenting. So don't worry about getting together any SOAP presentations. You're kind of just listening. At some point, usually first, you're going to round with the nurses at the 6K nursing station, just go through every patient and see if they have any concerns. Then you'll round with the floor attending and either the HEMOC attending or fellow. Both of those will be on the phone, just brief touch-ins led by the senior resident. Finally, you will round up in the PICU. Physically, you'll go up to 8 Kellogg and round with the attending and nurses all at bedside, but no formal presentations. Here's a list of wonderful shelf topics, things that always come up that you'll see. So if you see any of these things on the floor in the PICU, definitely try and pick those patients up. The more patients you can carry, the better. People are always really impressed the more that you try to take on. And if you have any questions, feel free to call or email us. Enjoy yourselves.